We'll go ahead and get started as people continue to pop on. I wanted to welcome everyone to this month's Multidisciplinary Fellow Forward Tumor Board. My name is Jeffrey Liu. I'm a head and neck cancer surgeon at Fox Chase and Temple, and I'm pleased to moderate this session and also work on behalf of the CDMS group. I really want to thank my colleague, Alice Lin, who's at Kaiser Permanente in LA, who really was instrumental in making this happen. Thank you so much, Alice. And as people continue to pop on, I want to welcome everybody. As usual, we will do 3 cases, approximately 20 minutes each. We have some great presenters today. We have David Forner, University of Michigan, who's a fellow, Jessica Tang from the MD Anderson Cancer Center, who's also a fellow, and then Andrew Larson, who's currently at Kaiser Permanente as our presenters. And we have 3 wonderful expert panelists to join us today. We have TJ Au, who's a professor at the Einstein Montefiore System in New York City. We have Audrey Baker, who's from the University of Arizona and an associate professor of otolaryngology. And we have Anthony Olzanski, who is my friend and colleague at the Fox Chase Cancer Center, who is a medical oncologist. He's also the vice chair for clinical research and the chief of the section of solid oncology. But we spent a lot of time handling melanoma and some of the ways that our melanoma team at Fox Chase Cancer Center. So thank you to all of our presenters, and thank you to all of our panelists. So, David, if you would like to go ahead and share your slides, we'll get started.
Great, thanks very much. I'm Dave Forner. I'm one of the fellows at University of Michigan. Thanks very much for the opportunity to present this case. So this is a case of a 58-year-old female who's otherwise healthy. She does have a history of tanning bed use and had multiple sunburns throughout her life. She was at the hairdresser, and her hairdresser noted a pigmented lesion on her scalp. Her physical exam otherwise just shows some actinic changes in a photo-distributed pattern with no other concerning lesions. We're fortunate enough actually to get a picture of this pigmented lesion here on her scalp. So this is her before, what her hairdresser saw. She ended up getting a shave biopsy first, which just initially demonstrated a combined nevus. She then went on to have an excisional narrow margin biopsy performed by an outside dermatologist. That ended up being reviewed at the Cleveland Clinic, and you'll see those results here on the next slide. And then she was referred to our way at the University of Michigan. So that excisional biopsy showed a nevoid melanoma of 1.3 millimeters thickness. They ended up with that narrow margin having a 0.3 centimeter margin. And she didn't really have any other concerning features per se, no ulceration, no satellites, no LVI or neurotropism, no regression, and just 1 mitosis. So she ended up with a PT2A NX-MX at this point in time.
Awesome. David, oh, that's perfect.
Yeah.
Can you go back 1 slide so we can see all the excellent data? So Audrey, so this patient presents in your clinic. What are some of the ways that you sort of size up the patient for workup and imaging prior to an intervention?
Well, it sounds like this patient has clinically negative nodes. Is that right, David? I missed that piece.
Correct, yeah.
Right. So, this is a patient I would have a discussion with about, I don't know how large the margins were. I think you said narrow margin excision. But this is a patient who I would discuss having a wide local excision in the operating room and at the same time having sentinel lymph node biopsy. It's interesting because now, a lot of these patients are coming in with preoperative genetic testing. I don't know if you're also seeing that in some of your practices, but many of my patients will come in with a Castle test that was ordered by their dermatologist and say, hey, I'm class 1A. The chance that this metastasizes is really low. Do I still need to send a lymph node biopsy? And to that I answer, yes, you do. Those tests are not great. And until we have really great data showing, some of the molecular testing, I think we still have to offer these patients the standard of care. So that's what I would do. At our institution, we don't use blue dye anymore. We found that it doesn't work as well in the head and neck as it does with some of the trunk and extremity melanomas. So we would just preoperatively inject her and take her to the operating room and find the lymph node and call it a day.
That's awesome. Thank you. What workup imaging do you do for these patients if they're clinically N0?
We don't do any imaging for these patients.
Okay. So you based it based on clinical exam alone?
Absolutely.
Okay. TJ, your thoughts on Castle Biosciences testing in this? If you get the results anyway, do you how are you integrating it, and what is your work of imaging?
We are not integrating Castle Biosciences for melanomas. That's easy answer for that. Just to back up a little bit, you know, when I get these referrals, I also worry a little bit about a couple of things. You know, they had it reviewed at Cleveland Clinic, and I'm guessing maybe at Michigan, but I always have my own dermatopathologist review the slides. I worry about a shave first and then a second, you know, excisional biopsy. Like maybe that's not the true thickness. You know, I want to really be sure about that, because if you go from T2A to T2B, you're actually in the realm of adjuvant therapy. You know, that's a big crossover, you know. You know, that picture to me looked a little more worrisome than the pathology report. So anyway, that's what I did. And as far as imaging, yeah, I think you know, for early stage melanoma like this, you may not, but I think again, given the history and because I didn't do the workup myself, I might like nudge it to a higher stage melanoma in my, you know, kind of my thought process, and I might get a CT neck just to be sure. Our ultrasonographers are have had a lot of turnover here recently, and I don't think I have as much you know, confidence in our ultrasonography here. So I would get a CT so I could look myself for necrotic nodes and large nodes and see if there's anything worrisome, you know, in addition to my own exam.
Okay, sounds good. David, you want to proceed? What happened next?
Yeah, so she does end up getting a wide local excision. 2 centimeter surgical margins were taken. And at that same time, a sentinel node biopsy was done. There was no additional imaging beforehand. This is her lymphoscintigraphy. So you can see a preauricular and a level 5 node lighting up. Some of her lymphoscintigraphy and spec CTs here as well for interest. And then I managed to track down some pathology, just as quick interest here. So just a standard AHNS stain. These are of her nodes, the sentinel nodes, which there was 3 removed. Here's an S100 stain showing some melanoma deposits here, subcapsular. More standard HMB45, and then some melan and PRAME stains, suggesting there's some melanoma deposits in these sentinel nodes. So ultimately, after the wide local excision, there was no residual tumor found at the primary site. So just as a reminder, original thickness of 1.3 millimeters, though excellent point that with the shave, this could have been more thick. She did end up being BRAF positive, and then those 3 nodes were all positive. So there was 1 in the parotid and 2 in level 5 each. The 1 in the parotid was 0.2 millimeter focus, and then the other 2 are kind of rare cells, less than 0.1 millimeter focuses, foci. So she ended up with a PT2A N2A MX for stage 3A at this point in time.
Thank you so much. And thank you for some of the molecular testing that can add to our conversation. Just out of curiosity, how did you reconstruct the defect?
This was secondary intention at this point in time.
So you kind of left it open to granulate, or did you use
Correct.
alloderm or skin graft, or you just kind of leave it open?
She would have been just left open, pericranium down. Yeah.
Very good. Well, let's go back to TJ for a second. I'll ask Audrey second in the reverse order. So TJ, if you see this, I'm sure you'll get your medical oncologist involved, but do you do additional imaging, or do you favor additional imaging at this point beyond any of the CT or ultrasound you might have gotten earlier?
Yeah, I mean, with positive nodes, I think you need to do a metastatic workup, you know, so I'd get an LDH. I would get a either a PET CT, although after an operation it might be a false positive, so you might get a CT chest, abdomen, pelvis, and we usually do get a brain MRI just to be sure there's not a brain met. So that, I think that's the pretty standard.
Audrey, what would you do? Similar?
That's the same thing we would do at our institution. You know, I have been getting PET scans right after an operation. Even after a couple weeks, you can kind of tell the difference between postoperative change and a frank mass somewhere else. We also routinely get brain MRIs, and I would send this patient to medical oncology. You know, the treatment of this patient over the last 10 years has changed drastically. I mean, when I was training, I'm an old lady, so when I was training, we were doing completion neck dissections for these patients. And, that has really fallen out of favor with the MSLT2 trial that was published in 2012. It's interesting because there are, as you guys know, there are some head and neck surgeons who would continue to do a completion neck dissection. There is a lot to be gained from that. But I think more and more people are coming away from that. I understand why somebody wouldn't want to go forward with a completion dissection in the axilla or the groin. I mean, the chance for lymphedema is horrible. There's a lot of, morbidity associated with those operations. But as you know, a neck dissection, I mean, that's no big deal. It's fun. It doesn't take that long. The risk of nerve injury and lymphedema is very low. And it can give you additional staging information if you have additional non-sentinel lymph nodes positive in the neck. That can be important for staging and prognosis going forward.
Thanks,
However,
Audrey. I'm going to pause you because I definitely want to revisit that point, but I want to have Tony kind of weigh in here because Tony,
Yeah, for
because I
sure.
definitely want to visit the completion lymphadenectomy and MSLT2. I think that's a very important point here. Tony, now this patient's in your shop. What are your thoughts on this case, and what do you think you would do?
Yeah, so to very briefly start, we never look at the Castle Bioscience reports because they're very confusing and they don't advance our treatment in any way. It's gene expression profiling. It's not codified by any of the major like NCCN panels and stuff like that. So this patient's very interesting because we actually do think that this patient could potentially benefit from adjuvant therapy. The FDA approved adjuvant therapy for patients with stage 3 disease. They don't classify stage 3A, B, C, or D. And so this patient would be potentially a candidate for that. Importantly, pembrolizumab and nivolumab, when they were studied, they actually didn't study patients like this. Specifically, if they had stage 3A with less than a 1 millimeter focus of disease, then they excluded those patients. They had to have stage 3A with greater than 1 millimeter focus. And then as we see on the slide here, we also have in this BRAF positive patient, Combi-AD, which is adjuvant dabrafenib and trametinib in a patient like this. So in this patient, because we really do have 3 nodes positive, I think we really have to think about a risk-benefit profile. If I had 1 node and I had less than 1 millimeter focus, I would probably talk to the patient about the cons and pros of therapy. Both of these therapies, immunotherapy or targeted therapy, are reasonable and rational in this patient. Again, I would offer the patient adjuvant therapy based on the studies that show improvement in relapse-free survival. I think a big difference right now and up for contention is, do you start with immunotherapy, or in a BRAF positive patient, do you do instead targeted therapy?
So Tony, I know that there's both excellent data for both adjuvant IO and adjuvant dabrafenib trametinib. Which one do you reach for first, and why?
I typically reach for pembrolizumab because it's every 6-week dosing. A patient only needs 9 doses in a year, and although some toxicities can be serious, life-threatening, or non-reversible, most toxicities are actually very mild, and it's easy to get patients through that for the most part. 80% of patients really have no significant toxicity. 9 doses goes really fast for patients. On the other hand, dabrafenib and trametinib has a higher rate of grade 3 toxicity, and you're taking at least 5 tablets. Some of them are tablets, some of them are capsules, but you're taking 5 pills a day. And when you multiply that times 365, that's a whole lot of tablets you're taking over the course of a year. Because the dose-limiting toxicity rate was about 50% with dab-tram, and the most significant toxicity is fever, pyrexia, seen in over 60% of patients, we have a pretty robust discussion of patients if we're going to start dab-tram.
Thanks, Tony. So, David, would you go back, I think, a slide to the actual pathology again? Tony, sometimes, Audrey very nicely outlined the MSLT2 data in summary that completion lymphadenectomy doesn't offer a melanoma-specific survival benefit. An overall survival benefit, but there may be some other benefits from local regional control, et cetera. As a medical oncologist, when you have a patient like this one, this is when, like, there's a couple parameters here, right? Is it single node versus multiple nodes? Is it like a teeny tiny less than 1 millimeter focus, or is it like E&E? Can you outline, you know, especially when, you know, you're working with your fellow head and neck surgeons, when do you say, hey, you know, maybe we should think about a completion even in the face of MSLT2?
So certainly for patients with big bulky lymphadenopathy that we found, or extranodal extension, those are the kind of things that start making me a little bit more nervous. The odd thing here is that if I'm going to start immunotherapy, and we'll talk about this as we get to some of the other cases, having antigen load at the tumor bed can actually possibly be helpful. And so eradicating all the disease with surgery might not be actually the best way to use immunotherapy, which is very intriguing thought. And we know that surgery in and of itself is a locally immunosuppressive, and just from the healing process, the inflammatory component itself. And so that could actually decrease the rate of pembrolizumab or any PD-1. We're not just talking about pembrolizumab here, and nivolumab has been approved as well. Those medications might not work as well as if we actually decrease the antigen load. So I think what really needs to happen, and what we're doing here, is we present these patients in a multidisciplinary tumor board, and we really discuss the pros and cons. And this is really helpful because the surgeon is going to know what that operation is going to look like. What are the real risks? What are the real benefits potentially? What is making the surgeon sway for or against TLND? And a medical oncologist is going to do the same thing. And we usually can come to some kind of consensus.
Okay, we have about 3 minutes left. So TJ, would you offer this patient a completion lymphadenectomy with this setting, with this, and or actually, let me rephrase. If this was your patient and you would discuss this in your team, what would your team recommend for this patient, completion or not?
Yeah, the short answer is in majority of cases now, we're not doing completion neck dissection for this. The discussion details, I still, I kind of presented to the patient that, you know, there could be the melanoma and lymph nodes in your neck. And even though it would make sense to remove those surgically, it has not shown to have a major impact on overall survival. I do talk to them a little bit about regional control, and then I kind of let them, we make a collective decision, usually the patient and myself, but they're kind of being steered away from the dissection at this point.
Okay. Audrey, what would your team offer this patient, completion or straight to IO?
We would go straight to immunotherapy, most likely.
Okay. David, you
Now,
want,
if there's a patient who can't get immunotherapy for any reason, then we might have that discussion as well.
yeah, that's a good point. David, do you want to finish out the rest of the slide deck?
Absolutely, thanks. So
Like, what did you guys end up doing?
Yeah, of course, multidisciplinary tumor board. Interestingly, she was close friends with a local dermatologist who was a huge advocate for her, and that dermatologist happened to be very prominent at the University of Michigan. That person came to all of her appointments with her. She was obviously very well informed due to this. She had multiple discussions with head and neck surgical oncology, medical oncology, and dermatology. She had a little apprehension with immunotherapy and targeted therapies, and so completion lymphadenectomy was offered, but she ultimately decided on surveillance, actually. So she got no adjuvant treatment and no completion lymphadenectomy. We ended up doing CT necks and neck ultrasounds, as well as some additional CTs. We did offer her and recommend a brain MRI, but she did not undergo this. She didn't end up having any additional regional disease or distant metastatic disease. She's being followed now. She's almost 3 years, 2 years, and almost 3 years, and she's still disease-free at this point in time, but time will tell, I suppose.
Thank you so much, David, for a great case. If you want to unshare your slides and Jess can bring up the next one. Thank you again for this really interesting case. We see this all the time, and for our panelists for a great discussion. Next will be Jessica Tang, who's at MD Anderson. Go ahead, Jess.
All right. So this is a patient who, 71-year-old, he came in with a 6-month history of an enlarging left supraclavicular neck mass, really had no complaints otherwise. And he, upon further digging, it sounds like he did have a very distant history of having a basal cell carcinoma of the cheek, and then back in 1999 had a melanoma in site 2 of the posterior neck. It looked like it was mainly midline, possibly to the right. It was treated with surgery, and he hadn't had any evidence of recurrence in that primary site since then. And I will say, given that he does have a lymph node with a technically unknown primary, there was a full exam done as well in the office, and did not identify anything in the oropharynx or nasopharynx as well, and there was no other obvious skin lesions. So this is some of the MRI that the imaging that he got. He did get an ultrasound. Ultimately got an FNA that did show malignant melanoma, and a PET CT as well that only showed a FDG avidity in that area that was palpable on exam. He also had a MRI brain that was negative.
Okay, let me pause you right there. So, sorry, you did say that there it is. Good. So this is do you have the next slide with a stage? I think
I do, but I also have what we ended up doing with.
yeah. So TJ, is this you agree with this workup?
I think so. Maybe throw in an ophthalmology exam. I guess you could have a uveal melanoma. But yeah, I think, I'd have a dermatologist. I might have missed it, but I have a dermatologist do a thorough body scan, make sure there's no lesion that we're missing.
Okay. Audrey, anything to add from the workup standpoint? Some PET, MRI, and
I mean, recent, and we never used to do this, but recently at our tumor board, we had somebody present like this who actually had an undiagnosed vaginal melanoma. So now we always say, oh, if it's a female patient, does this patient have regular OBGYN exams? But I can't say that used to be our standard of care.
Yeah, supraclav is a kind of a funny spot. So yeah,
It's
definitely
a funny spot.
rule out
Yeah.
an acral type of lesion for sure, which you might not think of.
And the PET CT didn't pick up the vaginal lesion, Audrey?
No, a PET CT did not pick up the vaginal lesion. It was like a mucosal lesion.
Interesting. So going back to TJ, so what would your team offer this patient at this point for unknown primary, single, it looks like a single focus in the neck?
Yeah, with an isolated, but it seems like a pretty large met. I think the two options for this patient would be surgery with adjuvant treatment versus neoadjuvant treatment followed by surgery. And I think more and more people are kind of leaning towards the neoadjuvant. I guess one other thing, the FNA probably isn't adequate to get a BRAF. So maybe a core, if you're not going to do, I guess if you're not going to do surgery, probably a core for sure to get adequate tissue to try to think of what type of neoadjuvant approach you'd use.
Awesome. Audrey, what do you think your team would do? And then I'll go to Tony next.
That's what our team would do. Exactly. We would make sure we have adequate tissue to delineate neoadjuvant treatment for this patient.
So both of you are favoring, Audrey, definitely neoadjuvant, and TJ, at least entertainment of neoadjuvant. Tony, what do you think about this case? And do you definitely want to know the BRAF status before initiating a next step versus kind of it's okay with what we have?
Yeah, so based on the emerging data that we have now from ECOG 1801 and the Abdulag study and the Prado study or the Opposite Neo study, neoadjuvant therapy really does seem to be the way to go. It is flooding the oncology community in triple negative breast cancer and lung cancer and many, many other areas because we're recognizing that we can get really great pathologic responses, which does seem to be a valid biomarker for relapse-free survival and potentially even now overall survival. So we're really much in favor now of neoadjuvant. This patient would have been a great candidate for neoadjuvant therapy because they have an unknown primary, but a clinically detected node that we can see on this PET scan. And so would fit all the criteria for the trial inclusion. I don't care about the BRAF status right now. I would get it. I would look for it clearly. But in the neoadjuvant setting, as opposed to the adjuvant setting where we don't actually know if IO or BRAF is better, we do know that in the neoadjuvant setting. IO therapy clearly trumps BRAF MEK inhibition. If we give BRAF MEK inhibition, there's about a 70% chance that this would go down or go away, almost a 50% chance of a complete pathologic response, which sounds wonderful, but the recurrence after surgery seems to be exceedingly high. Whereas if we give neoadjuvant immunotherapy, we see that the complete response rate, again, can be up to 50% if we're using dual immunotherapy. But on the other hand, we also see durability, and we see many, many patients never having disease again. So we would want to offer this patient neoadjuvant again in a multidisciplinary setting, but I'm almost always leaning now towards IO therapy. Very rarely would I pull the trigger on dabrafenib and trametinib or any other of the BRAF/MEK inhibitors, at least up front.
What is your IO cocktail of choice for a case like this? Are you doing ipi-nivo? Are you doing pembro? Are you doing with a LAG-3 inhibitor on top of it? I'm very curious because it seems like, I'm sure there are also trial opportunities, but I'm curious what you're sort of using off trial.
Yeah, so right now we're using a lot of combination immunotherapy. So that would be ipi-nivo. Ipi-nivo is actually flip dosing, so ipi-1 and nivo-3. It's a lot easier to tolerate. I teach my fellows that I can always get one dose of ipi-nivo into every patient. And in fact, in the Prado trial, there were 2 doses, 1 dose every 3 weeks before surgery. And in that trial, 90% of patients, 90% of 100 patients, so literally 90 patients, got 2 doses. Only 10% didn't. And those 10% that had immune-related adverse events did not have delayed surgery. They took these patients to surgery with steroids. It didn't impact healing, surprisingly to me, because I always hear the case that steroids are really bad, but these patients apparently did really well. And so I use ipi-nivo a lot. I do that based off of extrapolating from the metastatic setting, where ipi-nivo is the immunotherapy du jour because of the really outstanding survival that we have at 6 years. 50% of patients are still alive. Actually, melanoma-specific survival is better than 50% at 6 years, which is really amazing. So we're using a lot of ipi-nivo flip dose. Opdualag is using relatlimab plus nivolumab, a LAG-3 inhibitor, and it also has a pathologic complete response rate in patients like this of around 50%, actually 57% in a small 30-patient trial. So I think that's also a good medication to use. It has a much lower toxicity rate than ipi-nivo, and so we've been using that a lot. But the big trial, the biggest trial that we have, is the ECOG 1801, and that was about a 300-patient trial. And that used 3 doses of pembrolizumab, 200 milligrams every 3 weeks, and then surgery versus just doing adjuvant pembrolizumab. And in that trial, pembrolizumab neoadjuvant really did win, had a much better relapse-free survival. And importantly, though, if we look at complete responses, complete pathologic responses, that was only seen in 21% of patients. So pembrolizumab, 21%, Opdualag, 57% based off of a small trial, and ipi-nivo, complete response rate of 50%. So I usually pull the gun to try to give dual immunotherapy if I can.
That's great, Tony. Thank you. And I think the study you just referred to about neoadjuvant versus adjuvant randomized with pembro for N-positive disease or resectable disease with or without M1 disease is a link I just put in. Someone should check me, but I think that's the one I just put in. So great. Jessica, why don't you tell me what you did next?
So he did exactly what Dr. Olzanski had recommended with that specific dose. He was actually on trial, on the opposite neo trial. And he actually got randomized into that favorable arm with the low dose IPI of 1 mg per kg and high dose Nivo of 3 mg per kg for 2 cycles. He had that every 3 weeks. And then this was his response. So his PET scan really didn't show much FDG avidity at all. So the next step was to take him to surgery. And really, he had a complete posterior lateral neck dissection and had no tumor present. There was 1 lymph node, which was the one that was probably visible on PET scan that did not have any viable tumor cells. So essentially, he had a pathologic complete response.
Thanks, Jess. If you could just pause there for a second. Audrey, when you do these cases, do you do the 2 through 5? Like this is like more of a posterior level 5 lymph node. You do like 2 through 5 with a posterior lateral because you might think it might be a posterior primary that disappeared. Would you just be doing very focused 5A, 5B? I'm sure there are more lymph nodes here, but I'm just curious what you sort of think about in terms of what levels you would do for a neck dissection.
Yeah, I think it depends. For this was really a level 5 lymph node. I would do a thorough clean out of level 5, but it's pretty easy to get at least some of 2, 3, and 4 while you're in 5. So usually it ends up turning into a classic Boca neck where I'm doing 2 through 5.
Okay, TJ, 2 through 5.
Yeah, I think similar. I would like you don't know where the original primary was, but I think this looked like almost like accessory chain level 5 kind of thing. So I would treat it like a posterolateral type of lesion and do a posterolateral neck like they did. Plus, I
Okay.
treated MD Anderson, so I can't not do what they did at MD Anderson.
Can I ask a question here? In the Opposite Neo trial, complete lymph node dissection was required per that trial. But when that trial was amended and became the Prado trial, that was not necessary. And they did not do a TLND in all patients. So would you actually do a TLND if you thought that this patient had a complete pathologic response? Could you do an index node marker, take out that index node and get pathology?
Tony, great question. Audrey or TJ, who wants to take the first crack at that? If you know that it's likely to be a CR based on by the FDG avidity and maybe even a biopsy that was negative, would you still do like a limited or?
So in this patient, that PET scan makes me too nervous to call that a CR. So in this patient, I would definitely at least take out that lymph node. I would like to do a neck dissection. I'm glad that it turned out to be nothing, but that would make me pretty nervous. If the PET scan was like totally stone cold negative, yeah, I would talk with the patient about maybe just following with serial PET scans.
TJ?
Yeah, if a patient, even in a patient who had a complete CR, nothing on the scan, I don't know about you guys, but I can't find that one node. I mean, that's really impossible. So I think you have to at least take out a compartment. And if you're there, I think at least one level, essentially quote, like one level above, one level below that compartment is probably the safest approach at this point, and probably what I would do at the minimum.
Okay.
I
Tony,
think I'll just say one more thing because I think it's so intriguing. In all of the trials so far, imaging underpredicted pathologic response by a lot. And so it was not actually a good representation of what disease would or would not be there.
that was my exact question is, how good is the interval imaging after neoadjuvant prior to your definitive surgery? My understanding it's very poor at predicting that and there can be look like there's a residual disease that is a CR, or there can be look like there's been a profound response that is still residual disease. Is that right? I don't want to speak for you, Tony.
No, that is right. It's rare to have a CR on imaging and then find positive disease. That can happen, but it's rare. It's much more likely that you would have a PR or stable disease on imaging and then find that you've had a major pathologic response or a complete pathologic response. Complete pathologic response is defined as no tumor cells present. A major is less than 10% of tumor cells present. And in pathology, it's really nice to see necrosis, dead tumor cells, but fibrosis or scarring is actually even better because that's actually telling you that the tumor area, if you will, is undergoing real healing, and that is prognostically related.
Thanks, Tony. Dr. Neil Gross, thank you for joining. I see you have your hand up. Or was that an accident?
Yeah, no, I'm here. Thank you. And thank you, Jess, for presenting this case. Great, really great discussion. And, obviously this is an area that there's a tremendous amount of interest in. And I just kind of echo the comments that were made already around how imaging underestimates the pathologic response. And so that's sort of the holy grail now, both in melanoma is leading the way, but also in cutaneous squamous cell carcinomas, how to predict response better. And we currently don't really have a good substitute for tissue. But again, melanoma has led the way, and I think as was kind of mentioned, it is possible, and this is being done now at our Center for Melanoma, where you can mark the node of interest and then target that specifically for surgery. Now, personally haven't done a lot of that, and I'm a little nervous about missing the index node, but it certainly partly, I think, depends on the location and the risk of side effects, with a more complete dissection. Like, I think of a limited selective neck dissection a lot differently than like perhaps the side effects from a groin dissection or axillary dissection.
That's great. Thanks, Neil, for your comments. So Tony, can you break it down for me? So what would you recommend for this patient next, based on the pathology? Maybe you can outline when you have a path CR, path PR, or path NR, maybe those three buckets. Like, I'm sure each of those will be a little bit different.
Yeah, so if you actually look at the trials, the way they were treated was different, but the way that I treat them in clinic is essentially the same. I offer now everybody adjuvant therapy after they get surgery. I do it for every patient, and I do it for a couple reasons, a couple really intriguing reasons. If you actually look at the Prado trial, which was using ipi-nivo flip dosing, the primary endpoint there was relapse-free survival, and they were expecting to see one relapse out of the patients that they had. They actually had 4. So that that trial actually did not meet their primary endpoint of avoiding adjuvant therapy. Those patients got 2 doses of ipi-nivo, and then they did not get adjuvant therapy if they had a complete pathological response. So that trial essentially was negative, even though it gave us a lot of great data really supporting the use of neoadjuvant therapy. On the other hand, if you look at that same trial, they talk in the paper about patients who had non-response. So they did not have a pathologic response. And the patients who went on to get adjuvant immunotherapy did better than the patients who did not. And the interesting thing is, because I would put my hands up too, like, what in the world is going on? We see the same thing in lung cancer. We see the same thing in triple negative breast cancer. Patients who get neoadjuvant and don't have a response inevitably do better if they continue with adjuvant therapy with immunotherapy, even if they haven't had that response. And that would suggest to us that there may be latent responses, and that somehow the immune system figures out what antigen it's going to actually attack and go after it. And so based on the fact that we have that data now to support that, and of course, both the ECOG trial as well as the Abdullah trial used adjuvant therapy after the surgery in both arms. So in the neoadjuvant, they got neoadjuvant, then surgery, then they got documented adjuvant therapy. We're now following that as well for these patients.
If I could just summarize, you're not using the pathological response to risk adapt the adjuvant. You're just going to continue on with ipi-nivo at this point, at least in your practice?
So just to clarify, we don't continue with ipi-nivo. We just give the 2 doses of ipi-nivo up front, and then we'll give nivo out back.
Thank you. Got it. We have one more minute. Jess, you want to finish your slide deck?
Yeah, that was it really. So I guess the question was if you needed adjuvant therapy, which we had a discussion about. We actually, based on the trial, he actually did not, and he's been doing well since.
Excellent. Well, thank you. I thank you for that. I didn't realize that was your last slide. Perfect. Andrew, yes, thank you so much. If you wouldn't mind bringing up your slide deck. Thank you for a really great discussion. Tony, for the dense and very clearly articulated data, which I think is very dense, but it's always nice to find a great context for. So thank you everybody so far. Andrew, why don't you so Andrew, the faculty at Kaiser Permanente, and take it away.
Well, can you guys hear me?
Yeah.
All right, great. Thanks to Alice Lynn for inviting me to be involved in the tumor board. Having not long ago been a fellow myself, this was a great resource as a fellow. I learned a ton, so I'm happy to continue to be involved. This is a kind of a complex case. So what I'm going to initially present is a little bit of the background for this case. And we're going to go back in time a little bit for this. A 70-year-old male underwent wide local excision and bilateral sentinel node biopsies in 2012, so 12 years ago, for a vertex scalp melanoma. It was a nodular melanoma, 5 millimeters in thickness, so T4 primary tumor. There was ulceration, so T4B. There was no LVI in the path report at that time. They didn't comment on PNI. There was one micrometastasis on the right neck, level 2. Margins were clear. There was BRAF testing that was done at that time in 2012. There was no targetable BRAF mutation that was identified. In 2012, a completion right posterolateral 2 through 5 neck dissection was offered and performed. There were 27 lymph nodes were yielded from the dissection. However, there were no tumor deposits in the lymph nodes themselves. However, in some of the scar tissue around where the prior sentinel node biopsy was performed, there was a small perinodal soft tissue deposit, again, not within a lymph node. Almost more of an in-transit sort of situation. Stage is a T4B and N2C M0, stage 3C melanoma at that time. The patient had been offered adjuvant radiation. He declined. Systemic therapy was discussed. The documentation is a little unclear from this long ago about why he'd undergo systemic therapy at that time, but he was observed.
Do you recall what systemic therapy was offered, like IL-2 or?
It's a little unclear.
Okay.
All they said was systemic therapy in the tumor board notes.
The
what
only thing that was
a
available at
little
that
unclear.
time was interferon.
Yeah.
And it's no longer even on the market. Merck pulled it. It's no longer being utilized at all.
I thought when did IPI? I thought it, oh, not for adjuvant, just for, yeah, that's fine.
That's right. IPI,
Yeah.
it was approved in
for
2011 for
recurrent
metastatic.
Yeah.
Good.
All
Thanks.
right, well,
Andrew, carry on.
a perfect segue to the remainder of the case. So we're still back in time. We're still in 2012 at this point. 5 months later, there's a small nodule at the anterior aspect of the prior excision on the scalp. It was a small in-transit metastasis that was excised by a general surgeon at that time. So at this point, no adjuvant treatment had been offered, but has in-transit metastasis now, and was seen by a medical oncologist and placed on a clinical trial, placed on ipilimumab and an IDO inhibitor. The patient got 4 cycles, but did not tolerate this due to immune colitis and panhypopituitarism. So the patient was stopped after 4 cycles. So at this point, the patient stopped his treatment and was basically just put into observation at this point. He was followed by a medical oncologist for over 10 years. Okay, so now that brings us forward to the modern day. So now we are in 2023. The patient's being followed by a medical oncologist, develops a large right-sided neck mass that's palpated by an oncologist. You can see some of the MRI here, but it's quite an extensive posterior level 5 neck mass infiltrated into the floor of the neck, not surrounding the great vessels, but not involving brachial plexus, but kind of creeping in that direction. Biopsy was performed, showing recurrent melanoma, and molecular testing showing no targetable mutations, in particular, no BRAF mutations were identified in the molecular testing. So now the patient arrives at tumor board, and I'm going to ask, hopefully, for some input on this case.
Do you have any of the workup imaging that was performed?
So here's the MRI,
Yep.
and I have the PET scan. Somehow the PET scan here escaped. Sorry. So sorry, I apologize. I had a PET scan, it disappeared. It's basically just this area here, posterolateral neck lighting up. There's no distant disease. The patient had had a few lung nodules that have been followed for a long time now, but they've been stable, weren't lighting up on the PET scan. So it's just this regional disease here.
Okay, and MRI, I assume, was negative.
This is the MRI.
Oh, no, of the brain. I'm sorry. MRI of the
MRI brain is negative, correct.
Negative. So Audrey, PET scan negative, MRI brain negative. This is not the most surgical, appetizing case I've seen in a, well, what would you think about for this case in terms of next steps? What would you or your team think about?
Yeah, this doesn't look like a very fun operation. I mean, it's hard to say if we could try that. Um, if you made me, I might. But I think I would send this to a medical oncologist to see if they could use some magic potion, um, and and hope for the best. It's good that this is the only site of disease. However, it's really extensive. Um, if this, well, maybe I'm getting ahead of myself, but to die of local disease in the neck would be horrid, horrid. So this is a patient, even if it's not perfectly surgically resectable, if they can't or don't, if they don't tolerate immunotherapy, they can't get it, or if they're not responding to multiple different concoctions, then I wouldn't necessarily take surgery off the table with a reconstruction and post-operative radiation.
Hey, TJ, your thoughts on the surgical side and
Ye-
what you would do, your team would do?
Yeah, I think, I think the options for this patient are, largely in the immunotherapy realm. I mean, you could, from an operative standpoint, you're not going to approach this surgery thinking you're going to get thinking you're going to not leave disease in this neck. I mean, he's already told you with in transit mets and with dermal metastases that this is the cat's out of the bag. Like he's got, widespread disseminated disease. So I think, I wouldn't offer this patient surgery up front. I would offer them, kind of, immunotherapy approach, especially since he responded the first time. After 10 years, it could be more that his immune system's kind of getting kind of weakened as he's aging, and he just needs a boost from medication.
Perfect. Well, Dr. Oldansky, I look at you. I know there's a variety of different options. Some of them are local directed and some are more systemic directed. I'd be curious what you would consider for this case, especially in light of the that this patient is not IO naive, although that was a long time ago.
Yeah, it's a great case. And we do have some data to suggest that if patients go for, anywhere from 6 months to a year after immunotherapy, after they've already had a response, re-challenging them can often gain a second response. And we've seen that, especially in the metastatic setting. In this patient, obviously working very closely with my head and neck surgeons, that would be Jeff Liu, for example. Working very closely with these people. I would also recommend probably sending off this patient to radiation oncology to take a look at this and trying to determine whether or not they can map this out and think about radiation therapy, especially if the patient was particularly symptomatic or that tumor looked like it was going to erupt at any point in time or was going to be pressing up against the carotid or causing other kind of compromise for the patient. And why I mention that is because oftentimes it'll take, anywhere from 4 to 5 weeks for a radiation oncologist to come up with a plan. And I already am going to have a couple doses of therapy into the patient by that time. And if I see a response, we'll talk and oftentimes then abort the plan for radiation. But if I don't see a response, we're not losing time. And so that's really helpful. For this patient, I think we actually have 3 viable options. This patient never received combination Ipi-Nivo, did receive Ipi with IDO. That trial actually looked like a somewhat positive trial in controlling disease, but was really riddled with toxicity. There was another trial using IDO plus pembrolizumab, which actually showed a nice response in the phase 1 setting, also difficult because of some toxicity, liver function tests. But the phase 3 trial never manifested as positive. It was a negative trial. But that doesn't mean that IDO is dead. IDO is actually a very heavily investigated enzyme right now. And there are other trials looking at it, targeting it in different ways. So keep tuned because I think that there's some of the trials that are looking really, really promising right now. But for this patient, I would think about Ipi-Nivo. I would think about Opdualag. I am cautious though, because this patient did have colitis and panhypopit. I'm not worried about the panhypopit coming back because what's done is done. But the colitis could come back. Interestingly, the pre-existence of a immunotherapy-related adverse event does not help us predict what the next immunotherapy adverse event will be. it is about 30% likely this patient could have a recurrent colitis. That 10-year history might have changed things. So I would think about ipi-nivo, but I would probably shy away from it just because I don't like colitis. I might go to Opdualag, and this is a patient where I might actually suggest a single agent if I thought I could get away with it. But you know, most of my patients now are going to that Opdualag combination. The toxicity is really significantly decreased. About 40% of patients with toxicity with ipi-nivo, about 20%, 19% actually on the clinical trial with Opdualag.
Thanks, Tony. That's,
Yeah.
oh, go ahead. Someone has a
Oh,
comment?
Dr. Ozansky, can I ask you two questions? Is it known if you've had a immune-related toxicity to IPI, if you go to a PD-1 inhibitor, is the likelihood more or less same? You know,
Yeah, we see this all the time in the metastatic setting. We start with ipi-nivo. You know, the median number of doses you actually get into a patient is about 3 before they actually hit an IRAE. And that does not dissuade us from going to single agent. Once we control that IRAE with steroids or infliximab or vedolizumab or whatever we're using, we can almost always go to nivolumab. And I would say that the vast majority, probably close to 90%, tolerate it.
great. And I guess my second, sorry if I, but you know, the idea of combined radiation and immunotherapy, you know, there's a lot of philosophy that could be a good approach because you release these antigens with radiation and, you know, then you improve. But actually, I heard a pretty extensive talk recently on the data for head and neck, you know, trials looking at adjuvant immunotherapy and radiation. From what I understand, it's, you know, there really hasn't been, you know, that much almost worse outcomes with the combination. So, but I don't know the data in melanoma, and is that really something like, in my mind, radiation, if we embarked on surgery for this, if we did that, certainly post-operative radiation to, you know, perhaps get better regional control is definitely on the table, but I don't know the data for doing it up front.
Yeah, the only reason, and it's a great question, the only reason I would do it up front here is if I was worried about an acute problem because of tumor volume and my therapy wasn't working and we didn't feel that the patient would ever be operative, then radiation therapy could potentially help this patient. But what you're talking about, of course, is the abscopal effect. Abscopal effect being you radiate one area and some distant area actually gets smaller. And there was a lot of talk about whether or not that could be something that we could capitalize on with immunotherapy. But like in many other diseases, we're simply not seeing it pay out. Radiation therapy can actually cause a bit of an immunosuppressive environment as well. It does, we think, increase the antigen exposure, but that doesn't seem to have helped with immunotherapy efficacy to date, even in melanoma.
All right, thanks for clarifying.
Thanks, Tony. If this was a more favorable surgical resectable disease, are there any combinatorial off-trial options that would be like a local injection with an agent followed by surgical resection and then outback, or is that only on trial right now?
So only on trial right now. We do have TVEC, right? TVEC is a herpes simplex virus with basically a GM-CSF plasmid in it. It can be injected into this. It works best in the stage 3 setting, does not work in stage 4 as far as we can tell. Can work very well in stage 3. This is a pretty bulky node. It would be very difficult. You can get a maximum injection of 4 milliliters. Distributing 4 milliliters throughout this tumor would be a little bit too little. It's a big tumor. And so it certainly wouldn't be my first thing to do. I think this would be a relatively easy injection because the carotid and the vein there, the jugular, is far enough out of the way. So I wouldn't be worried about the injection, but it wouldn't be my go-to.
Jess, why don't you tell us what happened?
This
Oh,
patient.
sorry, go ahead.
That's
Andrew,
all right. The decision was made to give this patient neoadjuvant and adjuvant immunotherapy with surgery after the 3rd dose with pembrolizumab, modeled after the SWOG 1801 trial. Obviously, this is not the same setting. This is recurrent disease, but the treatment was modeled after that. The patient got 3 cycles of neoadjuvant Keytruda. followed by surgeries. Here you can see the staging scans after the 3 cycles of Keytruda, with quite a significant response down there in level 5 of the neck. I don't know if you can see my cursor. There is a little residual nodule here, but relative to the prior PET scan, the avidity has gone down drastically. Mind you, this was a revision neck dissection that level 5 had previously been dissected. But there were 2 primary nodules within level 5 that were resected. Cranial nerve 11 was able to be spared during the operation, and these were well away from the great vessels. There was only one of the 2 lymph nodes was positive with residual melanoma, and as had been previously mentioned, there was some extensive fibrosis as well as necrosis. The residual melanoma was about 1 centimeter in greatest dimension. So at this point, the patient is now undergoing adjuvant Keytruda by 15 more doses, and doing well on that thus far without adverse events on the immunotherapy.
Thanks, Andrew. And so far, a happy ending so far. Maybe Tony, make one more comment, like how many times, not specifically in this case, but how many times do you see in the metastatic recurrent setting that you have a durable response percentage that seems to be ongoing? It's a single-digit percentage, or they all met out eventually?
No, I would say that patients who have essentially complete responses or major pathologic responses like this patient, their prognosis is excellent, actually. Very few patients are recurring, and we can go back to some of the trials that we've already talked about, like the Prado trial, the Alpacin Neo trial, and look at those patients. In the subgroups that got just adjuvant therapy in this trial, in the SWOG 1801 trial, a lot more patients having recurrent disease as well in the setting of just adjuvant therapy. So neoadjuvant therapy is not only leading to great responses, but very durable responses as well.
Thank you. All right, we have about 1 minute left, and I need to do some housekeeping things. So let me start to wrap this up. First, I wanted to thank our presenters, David, Andrew, and Jess, for putting yourself in the line of fire for today and presenting some great cases. I wanted to thank some of our CDMS and AHNS Cutaneous section representatives, Dr. Cecilia Smallback, Dr. Tony Iskander, Dr. Arnold Bewley, Dr. Neil Gross, I think Dr. Steve Chen are some of the people identified on the call. If I missed you, I'm sorry. Thank you for being here and supporting the group and ready to provide some input. And I definitely want to thank my colleague, Dr. Alice Lin, who is the liaison for the cutaneous section, who really was instrumental in putting this whole panel together. I was just the guy who just hung out on the Zoom call and asked a bunch of questions. With that, I want to turn over to Mike Moore for some housekeeping for the next group, but I wanted to thank, of course, let me not forget to thank our presenters. Dr. Audrey Baker from the University of Arizona, Dr. TJ Au from Einstein Montefiore, and especially my friend and colleague, Dr. Tony Olzanski from Fox Chase Cancer Center. Tony, especially your comments from the medical oncology side are really exceptional. Thank you so much for being here. It's much appreciated. And with that, Mike, you want to finish up, close out?
Sure. Yeah, Jeff and everybody, all the presenters, thank you so much. Melanoma is, like I said, I feel like it changes daily almost. I'm curious what the version of this next year will be like, because it'll be, I'm sure, very much different as far as the subtleties of the approach. So thank you all. Very interesting cases, very thoughtful comments. And I think these pearls are key for the fellows to kind of put into context how we manage this challenging group, this challenging disease. So next month, June 5th, we round out the academic calendar year. So complex bone reconstruction, mid-face mandible, and more. Excited to have you all here. This will be hosted by our recon section. So thanks, everybody. I appreciate everybody's efforts. Have a great night.
Good night.
Thanks, everyone. Great
Everybody.
discussion.